Hello, friends. Happy Valentine's Day to all of you. Yesterday, we saw the cervical insufficiency diagnostics, cervical length measurements, and the classifications, etc. Today, let's look at the management. I partly touched upon the management yesterday. Today, let's just recapitulate the management part of it. I told you mainly there are three types. One is history-based cervical insufficiency, where cerclage is definitely indicated, and it is better done between 12 and 14 weeks. Supplement with progesterone is controversial. The second one is ultrasound-based cervical insufficiency, wherein there was one prior spontaneous preterm birth and TVS length this time is less than 25 millimeters. Definitely, cerclage is indicated before 24 weeks. Again, progesterone is controversial. The third one is examination-based, which is also called rescue or emergency cerclage. Cerclage is a reasonable option because we have seen better outcomes even in them. There are certain special situations wherein Singleton pregnancy who suddenly develops short cervix. But if there was no history of preterm birth in the past, probably these are the patients who may be treated with vaginal progesterone alone. However, placement of cerclage may be helpful in those with transvaginal ultrasound showing cervical length less than 10 millimeters. Maybe you don't have to wait till such time. Anything goes below 2 centimeters, you may consider cerclage in them. The other special situation is multiple gestation. The body of evidence does not support the efficacy of routine cerclage in multiple gestations. Note my words, routine cerclage. That means just because you see a multiple pregnancy, go and put a stitch is not correct approach. The body of evidence does not support that. But it may be useful in patients with classical history of cervical insufficiency or a short history in the previous pregnancy. Suppose the previous pregnancy was Singleton pregnancy, but there was a classical history of cervical insufficiency or a short cervix. Then this time she becomes, she has a twins, then probably it is indicated. Adjunctive behavioral counseling. This is very, very important, such as lifestyle interventions, that is cessation of work and exercise, abstinence from coitus, bed rest, limited activity. They have not been adequately evaluated by well-designed studies. Though these are very important questions, many patients ask us about these questions. Should she totally stop working and take bed rest? Because they're so scared that they may suddenly abort. Abstinence from coitus. Yes, what is called pelvic rest, that's the new terminology. The prostaglandins may be secreted in the semen, and that may give rise to uterine contractions, which may pose a threat on the stitch that you have put. So all these things cannot be conclusively answered because they have not been adequately evaluated by well-designed studies. Clinicians should consider the available evidence and the patient's individual circumstances when making lifestyle recommendations, as there are social, psychological, financial, and medical side effects associated with these interventions. So case by case, you have to advise the patients. So you cannot have a blanket answer for these kind of questions. Ineffective and unproven strategies. Yes, yesterday we had a wonderful talk by Dr. Narendra Malhotra on pessaries. He has done a first thesis in India, but I have no experience with prescribing pessaries for patients with a short cervix. One of my colleagues in Manipal had experience of a couple of patients using pessary. Maybe we have to do a thesis ourselves in Manipal. Dr. Malhotra has promised that. Let's see. In meta-analysis of RCTs, comparing use of cervical pessary with standard care, that is no pessary, In asymptomatic patients at high risk for preterm birth, that is cervical length less than 25 millimeters, but they are asymptomatic, pessary use did not reduce spontaneous preterm birth less than 28 weeks, 34 weeks, 37 weeks, or improve perinatal outcome. Obviously, we need to do probably more studies, even though this is a meta-analysis that came out, a 2020 meta-analysis report, which said it is ineffective, unproven. Well, now we know cervical encirclage is the most effective treatment for cervical insufficiency with or without progesterone. Progesterone part is controversial. Pessary is ineffective, unproven. That's all we have. So now onwards, I would like to talk in detail about the cervical cerclage. Cervical cerclage refers to a variety of surgical procedures in which synthetic suture, non-absorbable suture, it can be anything. I remember they used to give Sutupac earlier, then they used to give, Vicryl, non-absorbable, and some people even put silk and things like that, and some people even put nylon. Or tape is used to reinforce the cervix. So you are trying to mechanically close the cervix and hold the pregnancy. By mechanically increasing its tensile strength, the occurrence of adverse perinatal events associated with cervical insufficiency can be reduced. So that is the principle behind cervical cerclage. Most cerclages are placed via a transvaginal approach because that is easier approach, easily done, and are generally placed distal to the internal os, except in Shirodkars. I'm going to talk in detail about them. So as you know, Shirodkars is the one which goes as close to internal as possible, whereas others are in the infravaginal portion of the cervix. The transabdominal approach is more invasive, but allows higher placement at the cervico-isthmic portion of the uterus, probably most ideal, most anatomical cerclage. The transabdominal cerclage offered to patients that are unable to undergo a transvaginal procedure because they have very, very short cervix, so you don't know where to stitch them, or those who fail to deliver a healthy newborn after at least one previous prophylactic transvaginal cerclage. We have heard this many times. They have had one cerclage last time, but in spite of that, they went ahead and had an abortion or a preterm delivery, and they didn't have a live birth. So that's exactly why they prescribe transabdominal cerclage at this time. There are some absolute contraindications for cerclage that we need to know. Where procedure is unlikely to reduce the risk of preterm birth or improve fetal outcome, there is no point in putting cerclage. And not only that, there are absolute contraindications. What are they? Fetal anomaly incompatible with life. You have no right to lock this baby inside the uterus. So it is better that this baby is gotten rid of. Intrauterine infection. Again, cerclage is absolutely contraindicated. So we have to drain the intrauterine content or products of conception, only then will the antibiotics act. Active preterm labor. We all know what you mean by active phase of labor. Anything more than 4 centimeter dilatation is called point of no return. So there is no point in putting cerclage. If you put a cerclage, it will just cut through. Preterm labor, rather preterm pre-labor rupture of membranes, that is PPRA. This is a bit controversial. Sometimes in the absence of infection, you may consider a cerclage and give antibiotics and try to carry on the pregnancy at least few weeks. But by and large, if there has been a frank PPROM, the lower rupture, what we call, and if the liquor is less, there is no point in putting a cerclage and locking this baby up. It's going to go for an IUD. Yes, fetal demise is an absolute no-no for cerclage. It is better that fetus gets expelled. That is no-brainer. There is no point in putting the cerclage. at the same time, I can say another way also, if you have put a cerclage, if there's a fetal demise, that's an indication to remove the cerclage. So both ways. Active uterine bleeding, example, placental abruption. All of us know that placental abruption asks for an active management of pregnancy, labor. We have to deliver the baby as early as possible, whether it is alive or even dead. Otherwise, it will endanger mother's life. If the baby is alive now, most of the centers believe in doing an immediate cesarean section. Nobody wants to induce labor and wait for a few hours unless she's already got into labor and halfway through the labor. Only then will there be an indication for ARM and delivery. Definitely no cervical and cerclage if that's the case. However, placenta previa is not an absolute contraindication. It may be a relative contraindication, because if there is a central placenta previa, putting a stitch itself may induce contractions, or it may cause more bleeding and things like that. As it is, we say pervaginal examination is contraindicated in placenta previa, and imagine putting a cerclage there where you have to hold the cervix, you have to do manipulations and things like that. So depending upon the situation, it is said that it is not absolute contraindication, but mostly it is also a contraindication. Similarly, as I said, if you put a cerclage, if there's bleeding, active bleeding, it's an indication to remove the cerclage. So all these contraindications for cerclage are automatic indications to remove immediately if you have put a cerclage. For example, especially if she gets into active labor, if she has PPROM, if she has got frank pus coming out of it, if there's a fetal demise or active bleeding, these are some of the indications to remove cerclage. First of all, they are absolute contraindications. Secondly, if you have put a cerclage earlier and if they develop these things, it's an indication to remove cerclage prematurely. Now, lower and upper gestational age limits for cerclage. This is a very, very important issue. You know that you need to put a cerclage, but when to put a cerclage. If it is history-based, as I've already mentioned, usually we go for an early gestational age. But if it's an ultrasound-based, then we would like to wait till such time when the cerclage becomes inevitable. And of course, in an emergency situation, it could be any time. But let's look at the lower and upper limits. There is no consensus about precise lower and upper limits. That's usually the sentence in every article that you see. Most cerclages are placed between 12 and 24 weeks. Easy to remember also, 12 multiplied by 2 is 24 weeks. That reason is very, very clear. After 24 weeks, in most of the Western countries, they feel it is better to deliver them rather than lock the baby inside. And before 12 weeks, let's see. It is not performed before 12 weeks because results of aneuploidy screening may not be available. Even in fact, we do the earliest, we start around 11 weeks and 4 days, and most of us now prefer to do it at around 12 weeks to 13 weeks to be on the safer side to get the better results, and the results may not be available. Even if it is known that the fetus is euploid, waiting until the end of the first trimester permits sonographic evaluation of major fetal anomalies. You know that even in the first trimester, some of the major anomalies can be made out, for example, anencephaly and other major anomalies. So that's exactly why, by just waiting to complete the first trimester, automatically you have ruled out at least lethal anomalies of the fetus, and then only the anatomical problem will remain, and that is cervical insufficiency. I hope it's very clear why you wait till 12 weeks. Because I remember many undergraduates, ask this question. Sir, when you know very well that history-based, in cases, situations, when you know that she's going to have a problem in second trimester, why don't you put in the first trimester itself? So the answer is very, very clear. Controversial between 24 and 28 weeks. I said controversial because in India, for us, 28 weeks is the viable period or period of viability, whereas in the West, 24 weeks is okay for them to deliver. The procedure may cause accidental rupture, not just the question of delivering early or late. The procedure itself may cause accidental rupture of fetal membranes, leading to extremely preterm delivery with its attendant high risk of neonatal morbidity and mortality. That's also a problem if you try to put a late stitch, that is 24 to 28 weeks. However, each case between 24 and 28 must be individualized, weighing the risks of procedure against the likely outcome with the expected management. If you think that by giving her expected management, she's going to expel between this period, it is worth putting a stitch. I told you yesterday that even at 28 weeks, some people believe in putting a stitch as an emergency stitch or a rescue stitch, just to buy a couple of days to give the neuroprophylaxis in terms of magnesium sulfate and steroid prophylaxis for the lung maturity. So you have to individualize the case and decide about the upper limit. Lower limit, there is no doubt at all, don't do before 12 weeks, 12 to 13 weeks. Upper limit, you can decide case by case. Not performed after 28 weeks because birth at this age are likely to have a reasonably good outcome. This is again a Western standard statement, but in India, still many places, they are not comfortable delivering at 28 weeks, maybe even up to 34 weeks. Only after 34 weeks, many people are comfortable to deliver, at least to give this window of opportunity to give steroids and magnesium sulfate. People may still consider a stitch at 28 weeks. What are the pre-operative evaluations? Fetal assessment is at most important. As I said, if there are anomalies, no point in putting stitch. If there are problems with the fetus, that you have to consider. Confirm fetal cardiac activity and gestational age. So if the fetus is dead, you can't put the stitch. And gestational age beyond maybe, let's say, 28 weeks, there's no point in putting stitch. So you have to assess the fetus. Obtain fetal anatomic survey. As I said, if there are lethal anomalies, no point in putting a stitch. Offer aneuploidy screening if not already performed, especially when you are dealing with the early part of pregnancy. Evaluation for infection. Because in the presence of infection, you cannot put a stitch, and after putting stitch, if the infection develops, you have to remove the stitch. Cervicovaginal infection, it can be easily made out. Subclinical intraamniotic infection. Incidence ranges from 10 to 50% when the cervix is dilated more than 2 centimeters on physical examination and or membranes are prolapsed into the vagina. So in these cases, it is mandatory. Maybe you can take even a high cervical swab for culture and determine whether there's infection or not. Even nowadays, when we do ultrasound, if you see debris in the in the amniotic fluid, you can suspect chorioamnionitis, and you must treat them effectively with antibiotics. My first class, January 1st, I took the class on chorioamnionitis. Now the new terminology for that is called triple I, that is intraamniotic inflammation or infection. Please refer to that class. It is still on YouTube. Urinary tract infection also can affect contractions and preterm labor. And if you put a stitch, you don't know whether the stitch gave up or whether the stitch induced inflammation or urinary tract infection caused the problem. So a thorough evaluation is a must. Before unplanned procedures, that means usually a history-based and ultrasound is a planned one. But if it is an unplanned one, emergency, examination-based cerclage, observe up to 24 hours, even though you have physically examined and determined that it's a short cervix and you need to put a stitch, please observe for at least 24 hours to exclude PPROM. Sometimes high leak will not be very clear. Ultrasound will show that the liquor is diminishing. That means there is still leak going on. In these situations, sometimes we do AFI twice a day, maybe thrice a day, depending upon the situation. Preterm labor, occult abruption. Many a times we will not be able to diagnose abruption even on ultrasound. So we have to watch for her condition to whether it is deteriorating or whether it is improving. And of course, intraamniotic infection. So in a unplanned procedure, history-based and ultrasound excluded, whereas physical examination-based, you have to observe for 24 hours. Prophylactic antibiotics. Of course, this is an invasive procedure, and you may consider antibiotics to reduce the risk of intraamniotic infection. are commonly used before physical examination indicated procedures. Again, because these are the situations which are because of an inflammatory process and it's an emergency process. Strict aseptic measures may not be there, so prophylactic antibiotics are definitely indicated. Prophylactic tocolysis, what do you think? Considered because cerclage has been associated with transient elevation in prostaglandin levels and prostaglandins induce uterine contractions. So especially when you irritate the cervix like that, you poke the cervix, there will be some bleeding, and then bleeding in between the decidua can give rise to some prostaglandins, and there can be an increased activity. Even some people give a dose of progesterone just to relax the uterus, not as a treatment for cervical insufficiency, but to relax the uterus so that your putting stitch is easier. So that is considered. Indomethacin is commonly used before physical examination indicated procedures. In general, we don't give indomethacin as a tocolytic agent, but indomethacin is a good anti-prostaglandin prostacyclin. So that is commonly used before a physical examination indicated procedures. Use of these interventions is less common before ultrasound indicated procedures. That is usually a planned one. The ultrasound indicated and the history indicated is a planned one. Only the physical examination indicated is a rescue or emergency cerclage, wherein you need to quieten the uterus. Progesterone supplementation may be continued post-operatively in patients who are already on the drug. Now, carefully understand this sentence. In the previous three slides, I showed you that progesterone is controversial, but this sentence is different. This sentence says if the patient is already on progesterone supplementation or prophylactic progesterone weekly, sometimes people give progesterone weekly in cases of history of preterm labor in the past. Such patients, it is better we continue rather than withhold. ACOG and others have not made a strong recommendation for or against use of prophylactic antibiotics or tocolytics. Now, others means who? The ultrasound, obstetric gynecol, and then American Journal of Obstetric Gynecol, British Journal of Obstetric Gynecol, all these things. They have been basically silent maybe, or they are not recommending loudly. It all depends upon case-to-case basis. Most of us don't dare withhold antibiotics, and most of us are comfortable with tocolytics. But tocolytics should not be sort of continued. It should not be a strong tocolytic as such. It's just to relax the uterus. Anesthesia. Neuraxial anesthesia is preferred over general anesthesia for its overall safety, but either method is acceptable. If additional uterine relaxation is needed during the procedure, such as when the membranes are prolapsed, it can be achieved with IV nitroglycerin. Sometimes you want a total relaxation of the uterus so that when you give Trendelenburg position, the membranes will go back. Preparation, ensure that the bladder is empty. Placement of catheter for urinary drainage during the procedure is unnecessary though. Prepare vagina and cervix with the antiseptic solution, avoiding contact with fetal membranes if exposed. These are routine things that we do. Replace prolapsed membranes if present. Replace, don't try to push and do things like that. How do you achieve that? Place the patient simply in a steep Trendelenburg position to allow gravity itself to retract the membranes. As I said, if the uterus is relaxed by giving IV nitroglycerin and then you give deep Trendelenburg position, the gravity itself may take back all the fluid down there, and then the membranes themselves may go inside. Replacing prolapsed membranes, other things that you can do is administer uterine relaxant, which I already told you. Backfill the bladder in 250 ml increments through a bladder catheter. This is one of the methods, so that when it is bladder is being filled up, it will compress the cervix and slowly the membranes may go inside. Cervix apparently becomes a little longer. Place ring forceps. What you can do, in fact, just a blunt ring forceps you can put inside the cervix, and stay sutures of to hold the cervix up like that around the circumference of the external os and gently pull and shake like this, just try to put inside, help the membranes back into the uterus. There's something like we pull up a particular bag and then try to put everything inside. Push the membranes back with a smooth surface device such as gloved finger. Maybe sometimes you can just put a finger, ask your assistant to put a finger, or with a sponge-filled condom, bladder catheter balloon. And as you stitch, you put the Tenenberg and slowly ask the assistant to remove the finger so that once you put the stitch, everything is gone behind. If less invasive options are unsuccessful, all the options what I told in the previous slide are the less invasive options. If they are unsuccessful, you can actually do what is called transabdominal amnioreduction. A little bit of liquor is removed so that naturally the membranes will collapse into the uterine cavity. Under ultrasound guidance, reduces amniotic fluid volume and pressure in the prolapsed sac, allowing it to retract back into the uterine cavity. We hardly have done this. I have not done this at all. But that is one of the options, theoretical options that we have. And this is again a recent article. Approximately, you have to remove 150 to 250 ml if you want to achieve this successfully. Technical goal, of course, is reinforcing the cervix at the level of internal os, and of course, best achieved by Shirodkars. Lengthening of the cervix is a secondary benefit. When you put a stitch, especially with the muslin tip and things like that, there is an apparent lengthening of the cervix. The longer upper cervical length, that is cerclage to internal os, but not total cervical length, correlated with birth after 28 and 34 weeks gestation. That means the longer the length above the cerclage up to internal os, that is important. So not the total length of the cervix. Cervical height, that is again the length of the cervix between the cerclage and the external os, the lower part, the infravaginal part, was not an important factor in determining subsequent pregnancy. See, you remember that I told you T and Y and V and U. Where does it start from? It starts from the internal os, isn't it? That's why the portion above the cerclage is very important, not below the cerclage. That's what is the meaning of this sentence. Achieving a cerclage height more than 20 millimeters, that is 2 centimeters, reduced preterm birth compared with shorter cervical height, obviously. And a whole lot of systematic reviews are there to support this particular sentences. Systematic review 2017, 2020, and other articles. Now I come to individual procedures like McDonald's. All of you know, it's the simplest one. It's like a purse string sutures. As you can see here, you can start either from 12 o'clock or you can start from 6 o'clock, whichever way, but you avoid the 12 o'clock, 9 o'clock, 6 o'clock, and 3 o'clock position, especially 3 and 9, because descending cervical branches are there. So as you can see here, the loop comes out. You are not exactly at the 9 o'clock. You may be slightly above 9 o'clock and below 9 o'clock. Similarly here, lateral to 6 o'clock and medial to 6 o'clock. Here again, below and above 3 o'clock. Can you see that? You don't exactly include the cervical artery, descending cervical arteries. So ultimately, if in the exam you are asked to draw the diagram, it is drawn like this, like a beautiful flower all around. And Shirodkars, of course, you have to do a posterior dissection to send at the sutures there to the up to the level of internal os. Then there is an anterior dissection also you have to do, somewhat like the initial steps of vaginal hysterectomy. And you have to reflect the vagina and push the bladder up. And after that, you put the stitch here. As you can see, the stitch is going at the level of internal os. It is done. And then you close the vaginal walls. So the picture is drawn like this. And then you have a very dire emergency, desperate stitch, what we call Wurm cerclage. Just one, it's like one above downwards. And you can see here, this is usually put when the cervical os is so big. And one row. And in this particular stitch, there are chances that you may go through into the membranes. And that's why it is very dangerous stitch. The final picture may look like this. So I will show you all the 3 types of pictures. This is usually asked of the PGs to draw in the examination. So you draw like this: McDonald's, Shirodkar's, and Wurm stage. Now, Shirodkar and McDonald's, as you know, Shirodkar cerclage is placed as close as possible to internal os after surgically reflecting the bladder anteriorly and rectum posteriorly, not rectum actually, the posterior vaginal wall. And McDonald's cerclage is a pursing suture that does not involve any dissection. Thus, theoretically, it cannot be placed as close to the internal os as Shirodkar's. And these are the oldest. Shirodkar actually was the first one, 1955. McDonald's came later, 1957. So modifications of both have been described. Plenty of modifications are there. How do you choose between this? The body of data shows no significant differences in pregnancy outcomes between the two procedures. Thank God. So anything and everything is okay. This includes 2021 article, which is a FIGO good practice recommendations on cervical cerclage for prevention of preterm birth. And there are a whole lot of 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 articles saying that there's no difference, so you can do whatever is comfortable. However, no randomized trial has compared the McDonald's Shirodkar procedures directly. It's all indirect procedures, but good enough for us. Number of cerclages. A single cerclage is usually adequate if well placed. In some cases, an inadequate initial cerclage is used for traction. That means, like, in episiotomy, if you cannot get to the tip, you put wherever it is possible and then you drag and you can go to the tip. Similarly, you put wherever it is possible, hold that as a traction suture, drag it, and then you go higher up. That's the meaning of this particular thing. Or a second cerclage may be needed to achieve adequate closure of the cervix when the procedure is performed on a widely dilated cervix with prolapsed membranes. So that means initially you put a rough stitch beyond the membranes, and after some days, maybe you can consider another stitch when all the membranes have gone inside and patient has been in the Trendelenburg position in the ward. If two cerclages are placed, they are generally removed at the same time. It's not one after, not depending upon when it was put. Practice of routine second cerclage did not improve outcome in 3 retrospective studies. So don't have to put 2 cerclages all the time. A RCT found that the placing a second stitch at the external os to keep the mucus plug in place, termed sometimes cervical occlusion, did not increase gestational age at delivery or decrease neonatal intensive care unit days or neonatal mortality. So simply don't put too many stitches. Post-operative care and follow-up, hospital discharge. Cerclage is typically an outpatient surgery procedure. Sometimes you may admit for a daycare procedure. Most patients can be discharged after recovery from the anesthetic and when able to ambulate and void urine. However, a longer period of in-hospital observation may be indicated for some patients who undergo physical examination indicated cerclage because they are the rescue cerclage, emergency cerclage, because of their increased risk of complications, obviously PAROM infection, etc. Documentation of fetal heart rate and normal amniotic fluid volume should be documented prior to discharge. Analgesia and acetaminophen can be given. What to expect? Some spotting, cramps, dysuria, and increased frequency of uterine contraction, all are possible. When to call the clinician? When you discharge the patient, tell her if there is leaking of the fluid from vagina, if there is vaginal bleeding or spotting, she must immediately report. Activity, maintain pelvic rest. That's avoid coitus. Patients who have had ultrasound or physical examination indicated cerclage are managed more conservatively. Follow-up. Patients followed as outpatients are seen on a regular basis with frequent, it is weekly or biweekly visits on clinical for cervical examination by ultrasound. When do you remove the cerclage? Of course, the timing is 36 to 37 weeks if there are no other indications, emergency indications like intrauterine death, bleeding, leaking, infection. Otherwise, just 36 to 37 weeks. Or immediately upon onset of preterm labor, to avoid cervical laceration and uterine rupture. Very, very rare. Whether to remove the cerclage in the setting of preterm pre-labor rupture of membranes is controversial. I told you already, very, very rare situations we may continue with the cerclage because if there's no infection and leaking is very less. Site of removal, of course, McDonald's cerclage usually can be cut and removed in the office without analgesia or labor room just before induction or section. We usually remove in the labor room when they're admitted for delivery. What are the complications? The frequency of complications is higher with increasing gestational age, obviously, and cervical dilatation, but not higher with McDonald versus Shirodkar. Even in higher gestational age and higher cervical dilatation, McDonald's is simpler compared to Shirodkar. That's the meaning of it. In a study including 38 history-based, 96 ultrasound-based, 145 physical examination-based cerclages, the incidence of preoperative complications differed significantly, lowest being in the history-based 7.9, 10.4 in ultrasound-based, whereas 27.6 in the physical examination-based. It is Journal 2022, Obstetrics and Gynecology. So membrane rupture is usually in the history-based. 65% of the procedures it can happen. In the absence of preoperative rupture, risk of PPR at less than 34 weeks of gestation may not differ by cerclage indication. Intraamniotic infection, a history indicated and non-history indicated cerclage was 2 versus 25%. Maternal sepsis has been reported after history indicated. Suture migration, a very rare thing to happen, reported in 3 to 13% only. Others like cervical dystocia, even if you remove the stitch, the cervix may not open up. It is so tightly held. Or cervical trauma in labor have been reported in fewer than 5%. All 22 article. Uterine rupture as a consequence is very rare, as I told you already. Excessive bleeding and fistula formation is also rare. Finally, the outcome. Most case series report a live birth rate of 70 to 90%. That means thumbs up for cerclage. After history indicated cerclage as compared to 10 to 30% prior to the procedure. The timing of cerclage also affects the outcome. There is universal agreement that physical examination indicates cerclage performed in the presence of advanced cervical change and prolapsed membrane has got worst outcome. I have told this many, many times in this particular talk. That is Cochrane review. Thank you very much. I will come up with another topic maybe tomorrow. We will have a new topic. Thank you very much.